For years, ICU teams have been told, avoid propofol for rapid sequence intubation. Why? Because it causes severe hypotension, even cardiovascular collapse. That came from the INTUBE study and multiple observational trials. But here's the problem. No prospective randomized trial had ever directly compared propofol to ketamine for RSI in critically ill adults until now. Enter the PROMIN trial, published in Intensive Care Medicine in March 2026. Over 170 critically ill patients requiring RSI were randomized to either ketamine at 2 milligrams per kilogram or propofol at 1.5 milligrams per kilogram. The primary outcome was the lowest mean arterial pressure within the first 10 minutes after induction, and the result? The lowest MAP was 66 with ketamine and 60 with propofol. That's a mean difference of just 6 millimeters of mercury, barely clinically meaningful, and the p-value was exactly 0.05. So yes, propofol caused a slightly lower early blood pressure, but here's the kicker. That difference lasted only about 10 minutes. By 1 hour, the average MAP was the same in both groups. Cardiovascular collapse was more common with propofol, 33% versus 22%, but that was driven entirely by a brief increase in vasopressor doses, easily overcome. At 24 hours, vasopressor requirements were nearly identical. Now here's where it gets really interesting, and a bit uncomfortable for ketamine fans. Day 7 mortality was 33% in the ketamine group versus 23.8% in the propofol group. ICU mortality 59% versus 47%, hospital mortality 60% versus 50%, all numerically higher with ketamine. But let's be clear, the trial was not powered to detect mortality differences. These numbers could be due to chance, but the consistent direction across all time points is a signal that needs further study. So, what are the limitations? Only 2 ICUs in Brazil, generalizability, unknown, open-label design, unavoidable. And this was a controlled trial. Would propofol cause more trouble in routine, less monitored practice? We don't know yet. But here's the bottom line for you, the clinician. The presumed hemodynamic advantage of ketamine over propofol for RSI, the reason many of you reach for ketamine first, is not supported by this randomized evidence. The difference was small, transient, and not clinically meaningful, and propofol was not the villain we thought it was. Larger, pragmatic, multi-center trials are needed, but until then, don't choose your induction agent based solely on fear of hypotension. The best available data says, it's time to rethink that reflex. Follow for more evidence that changes practice, and check the link in bio for the full paper.